Hey, GLP-1 plus size community. Before we jump into the podcast, please take the time to leave us a 5-star review on whatever audio platform you're listening to the podcast on. Share your story and how the podcast has helped you. This will help us get referred up in the audio platform so that we can reach more people that need our help, our support, and guidance from our doctors. Help us get loud and change things.
Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on the Plus Sides, Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus Sides, Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault. You want to know a hack to get insurance to cover your GLP-1 prescriptions? Here's the truth. Most people get denied the first time that they try, and insurance companies are betting that you're just going to give up. But you do have rights, and you can appeal not just once, but multiple times. The problem is the process is confusing and it's time consuming, and a lot of providers just don't have the bandwidth to be able to fight through it with you. So that's why I partnered with Claimable. It's an easy-to-use tool that helps you build expert-backed appeals proven to work. So don't give up on your shot at coverage. Exhaust your appeals. Go to getclaimable.com/plussides to learn more and use code PLUSSIDES with a Z to save.
Want the fastest working GLP-1? For half the price, Ro now offers FDA-approved weight loss injections cheaper, with results you can see faster. Lose 15% of your weight with the formula from Eli Lilly that hits not one, but 2 hormones to curb hunger and nausea. Weight loss faster, confidence higher, price cheaper. See if you qualify at ro.co/TV.
I mean, I think we have that. Yeah, we've had a lot of effects on a lot of people, and there's so much like geopolitical stuff that goes into it, right? Like whatever's happening in those times, how people are responding, what it's doing to their food sources, what it's doing to their activity levels. There's so many variables that we have to control for. And then I think, in this modern day and age, like I look at my own family history, and my grandfather had diabetes at 37, never took a med a day in his life, but he was a civil engineer and walked all of his projects and owned acreage and farmed peanuts and grapes. And so he was walking all day. Wow. Never had a problem, had a stroke like near 90, but lived a long, good, full life without ever having to take a med, right? But then you look at our generations that have come here stateside, and we are more sedentary. We have more access to food. We are not as, we're just not moving as much. And you see that disease start to come out. And I think it's the same thing with our Native American population. I see this in a lot of my patients who have Irish heritage, and they really struggle, because of what our ancestors have been through. So, there's generational medical trauma. If you
wow, more things to study, huh?
Yeah. So we got lots of things to look at and to study.
Yeah, it just goes to show what is it? We're the people. I always say the people who have the propensity for obesity are more just better equipped for the famine. So
yeah, zombie apocalypse. I'm surviving.
Yes, it's fine. I've got this covered. Like I will be very efficient, and you will all want to be friends with me.
Today's supposed to be the rapture, so there we go. So
yeah. I'm not very
not
sure.
really
So I think I'll be left behind.
Speaking of controversial things,
We're talking about a lot of things
Yeah.
that have been on TikTok today, guys. Like it's just, it's
I
been
need
a
to go.
crazy freaking week and it's only Tuesday.
I need to go catch up. I was in clinic all morning up until I met you guys, but I've been hearing snippets from my patients.
Well, you know, Rapture, that's one.
Mhm.
People giving away their money, and I'd have been like, I'll do it. And then the other one is, you know, Tylenol is the reason for autism.
That I
because of
saw
Tylenol.
yesterday and it pissed me off. So
Yeah.
that one's been hot and heavy on my mind.
I can't even. I was really hoping for something a little more profound, like this, you know. I don't know. I mean, I wasn't hoping for anything. Let me rephrase. But I guess I thought when October came around, it was going to be like this huge thing, not this. And I just can't even take it serious, which is why I'm making jokes about it.
Yeah.
Sorry, we're not even in October yet. So
no, it's like a laugh or you'll cry type scenario.
That's exactly what it's like.
Yeah.
I'm not receiving this message. I need more data. This is not
all of my friends who are gynecologists, like obstetrician gynecologists, pediatricians, infectious disease docs, they are like pulling their hair. You know, it's a rough week.
I can't even.
It's like, keep on.
That's where I'm at. And keep in mind, like autism is very close to my heart. My husband's autistic. My son is autistic. So I would think I would be like mad and stuff, but honestly, I just find it so absurd. I just like, I couldn't help but make a joke about it. It's just insane. So anyway,
I understand.
I will be waiting. I'm going to candidly say I will be waiting for more data to support said claims today.
We'll see. Isn't it like I think Tylenol was created after the first case of autism? You know what? Let's not fall down that road.
We could go down that rabbit hole and miss the entire point of this podcast.
Another day.
Exactly.
Speaking of controversy, like what are your thoughts on Compound?
Oh yeah,
that's a good question. I will say that I don't have a ton of experience with them because I have some restrictions around my malpractice that allow me to prescribe, right? And I think that
anything.
I have up to a certain percentage of things that I can do, but there are certain ones that say like no compounding GLP-1s. They're okay with compounded testosterone, but not. Yeah, it's really kind of interesting. And I think I'm a little spoiled in Washington State. We've had more access through insurance plans because we live in a tech area where people have a little bit more access. And so we've been able, and you know, I was using them off label for obesity in my patients with type 1 diabetes.
Yeah. Really?
For years prior to the obesity indication. So I know what, you know, these GLP-1s do. And I know that you can kind of adjust between doses so that people are not getting the side effects. But to be honest, I have not been able to prescribe compounded ones just because of what that I see as a barrier, right? Honestly, because I think one of the things we had kind of discussed leading up to this was like, what are the barriers? I think part of the barriers, the obvious ones are coverage and cost and, you know, availability in pharmacies and pharmacies choosing to actually offer these. Like I know for a while CVS was jumping back and forth. I get so confused between what they're doing to insulin and then what they're doing to GLP-1s. Every week I just tell my MA, I'm like, okay, so what's on the docket today? Like who's allowing what? And we'll just go from there.
Was it Washington State where there is a that was the first case where the woman did she sue for rights to get access to GLP-1? I think it was
Washington. I don't know. Was it?
I think she dropped it, but in Washington State, obesity is considered a disability.
Oh, fascinating.
Sabina,
and so she was trying to say because it's a disability, they should provide access. I think the case got dropped.
Okay.
But
I'm going to have to look that up. Actually, I'm going to take a note, right? So that I personally think that, you know, restrictions on, you know, fear around malpractice, because at the end of the day, I want to be able to continue to do what I do for patients.
Yeah.
It's going to tie your hands to doing stuff. Now, have I gotten creative during the shortages with like Mounjaro and Ozempic, and do I, you know, microdose and have people inject stuff into vials and then draw it up with, yes.
There you go.
We got the drugs in a way that, you know, the insurance is not mad about it. We're not going over the doses that are allowable, but there are some of my patients who feel crappy on 1.7, not quite enough on 1, and we find somewhere in between that works for them. And that's just kind of how you got to do it, right? Because we are so genetically diverse. What works for you is not going to work for me, is not going to work for the next person walking down the street. And when I used to be on faculty at University of Maryland, like earlier in my career before moving to Washington. And the head of my division there was also the head of the division of personalized genomics. And we had this Amish community in Lancaster, Pennsylvania, where they allowed him to come in and do the research with that closed group of families, because I think it's like 14 families over 400 years, right? So there are a higher preponderance of genetic disease in that population. And so he actually did some research that they found, like, there's a medication we give people when they get stents in their heart called Plavix, but there's a small subset of the population that actually gets more clots in their stents when they get put on Plavix. So they were able to find what that gene mutation was at, they check for that gene mutation when people go into the cath lab at University of Maryland, and it changes therapy, right? We really need to at some point do that for all of our meds, but I think what people do with our genetic data is still highly unregulated and a little scary. So we may not see that in our lifetime, but I think in some future state we may see that, where we are picking meds based on people's genetics. There's already tests for, like, I think for medications for mental health disorders and things like that, that you can pick based on your genetics to see which ones you'll respond to better. I would love to see that for all of our GLP-1 agonists. I would love to see that for the thyroid meds that I prescribe, or for the other diabetes medications I prescribe, right? I would love to be able to pick based on what is right for you and your body and your situation. So, right now that's why we call it art and science, because the science generally has been done in mostly men. And then when you layer in women, it tends to be more white men and women. And then you add in all of the other minorities, and there's just not enough data. So we're doing a lot of extrapolating, and that's where the art piece of it comes in, where you are adjusting and trying to figure out what works best for your patient.
So I could say that I know of a lot of companies in the space who are trying to do customized medication, GLP-1 and other things based on genomics. And so that's coming. Now, does it mean that the correlations that they're making are scientifically sound, or is it just a novelty? Like all the tests that, like, you don't need 200 blood tests, right?
Correct.
I don't know, right? But I see kind of in the health tech startup space a preponderance of more genomic testing, because it's become more affordable and accessible, that will be correlated to treatments.
And I really hope so, because I think if you go back like a few decades, it would take them a whole day to sequence somebody's genome. They can do it in under an hour now.
Wow.
So it's coming. But to your point, like, are the studies well done? Do they actually mean something? Is it going to change people's outcomes? There's so much research that has to happen for that to be convincing.
Absolutely. And I think, like, as more of these become available, single agonists, double agonists, triple agonists, like, to be able to know and hopefully avoid, like, getting sick or going through the insurance hoopla to get things approved, and, like, know what you would do well on, I think would be good. And I remember they had something recently where they were testing sort of, like, I want to say it's like gut motility or something like that, where that was a thing, right? Where they could be like, maybe why some people do respond to GLP-1s and other people don't. Right?
Yeah, because the gut motility piece of it is how quickly the food moves through your GI tract, right? So when you eat something, if it moves slower, you feel full faster. It signals to your brain when it's moving slower that you're full, and so you won't eat as much. And actually, when my patients start on their GLP-1s, one of the common side effects, the nausea, is I tell them that's like cognitive dissonance between your brain and your stomach. You're used to doing something through your actions, and your habit is to eat a certain amount, but your stomach is slowing down, and it's not going to feel the same anymore. The same food you ate is actually going to make you feel, the same volume of food you ate is actually going to make you feel nauseous nauseous or nauseated. What is the proper term? I don't know. But it moves because it's moving through your GI tract slower. You're going to feel full faster. And if you eat past that point of fullness, you're going to feel nausea. So when people are aware of that going into it, they watch for it a little bit more. But everybody goes through that adjustment period. I know I felt it when I started on a GLP-1. So
yeah. Can I tell you about something about my journey? Was that when I got started, especially in the first 2 weeks, but certainly in the first like 2-3 months. So I'm a canary for nausea. Everything makes me nauseous. And what it felt like was my entire GI tract felt fucked with. Like it was just different. Like everything was like touched by the GLP-1. Like literally everything got touched. And it felt like it took me a while for me to understand that I basically had to relearn my body's cues for my entire GI system. Hunger felt different, like needing to poop felt different. And what I realized was like my body was just giving me nausea, a signal for all of that. So like I could be nauseous and I'm actually just constipated or thirsty. Or like I need to burp or I need to fart or I'm hungry or I'm thirsty, right? And I had to completely relearn and also take the nausea in context of like, have I eaten recently? Maybe I'm nauseous because I need to go eat something, right? Of like using my brain of just in the context of where I am today, related to my GI system. But my body was just like nausea. Nausea is the cue for everything now.
Yeah. It's funny because I hardly ever actually feel nauseous at all anymore, because I don't think I even know that it's nausea. I think it's just my cue. And I've been on that so long, I've learned. My brain's been like, oh yeah, we need to drink some of that. We need to eat something. We need to go poop, like whatever it is. I do. It's one of like, cause I don't know how much you know about like how this all got started with me and Kat and stuff, but I used to do lives constantly. And the reason I did is because the amount of doctors that were prescribing these medications at like starting at 2.4 for Wegovy because there was a shortage and all of these different things. And so when that happens, then people don't trust their doctors. And guess where they come? To TikTok, to me, to Sabina, to Kat, right? And so here we are, like what Dr. One of the doctors on our show that was the former head of the FDA was talking to us about like we're like patient educators. We sort of become this part of this community. And we're not giving medical advice, but we are saying like, hey, stop doing that. If you're throwing up, go talk to your doctor and ask this question to your doctor, ask this question, like things like that, because ultimately the trust is very, very broken between doctor and patient, and so we've sort of been filling this gap, and the gap is just, honestly, I would think it's closing a little. I feel much more comfortable with the people who are, getting specialized in obesity medicine and endocrinology, because I do think that, they tend to understand insurance processes and approvals and PAs best. And they also understand the disease and how the medicine treats it and can guide our community best. However, there's just not enough of you. There's just not. We are all so sick, and there's just not enough. So then we have these telehealths. Go ahead, Kat.
I was going to say, how can we find more of you? Go ahead. Keep going.
That's a great question. I think, again, this generation of medicine has inherited a crisis that was not of our making, right? If you go back and you look in the 80s and 90s, where people were in bed with pharma, they were doing procedures that didn't need to be done, they were charging high prices, they were prescribing meds, it created such a degree of distrust, right? That government regulation had to step in, and it was kind of like Thor's hammer that came down instead of like, stop doing that, right? And what happened was we got so tightly regulated, and the voice of healthcare providers went away because of a few bad apples, maybe not a few, but maybe like a bushel or two, that now we are fighting distrust from, government and insurance companies who are seeing that as a profitability margin. And then there are patients who were not served by the previous system or misserved by the previous system. They don't trust you no matter what you say, right? And that is a really hard thing to then have to try and fix in a 15 to 30 minute visit, right? Like sometimes the amount of time that you have for a visit is very short. I actually fought with my healthcare system, and I was like, I need 45 minutes for new patients minimum. It used to be an hour, so I backed down to 45 because the longer I've practiced, like the more I can get out of patients. But my follow-ups are all 30 minutes. Unless I'm seeing you virtually, those go faster because we don't have the check-in process. And those will be like 20, 25 minutes. But I advocated for that time with my patients because it's just not possible, right? And unfortunately, our primary care docs don't have that luxury to go advocate for that, right? And it's really hard because in this country, our healthcare insurance, everything is tied to your job. And if your job is just holding all these things over you, it's very hard to fight the system. And so I just want to say to all the listeners out there, the overwhelming majority of doctors are good. We don't want to see you sick. We get no financial benefit from anybody for, whatever garbage is out there on the internet, like meds, vaccines, whatever. I've been practicing for 16 years. I have yet to receive my check. Nothing has come, right? And most of us want to see you get better, and we want to do right by you by giving you all of this support. I think with endocrinology, one of the interesting things has been that when it comes to reimbursement and healthcare stuff, we are one of the specialties that you do because you love, not because you're going to make a ton of money off of it. We get probably reimbursed at or around maybe even slightly lower than primary care in some areas. And unfortunately, with how expensive medical education has gotten, people don't go into those specialties anymore, right? So you're seeing a shortage of that. And then in my perimenopause and menopause work, one of the other things that I've come across is that one, I think it's fabulous that we have more women going into medicine. I think we absolutely need that. We need it because we need to advocate for our own healthcare causes. Unfortunately, the system is set up in a way that women almost can't succeed in it. And by year 6 of practice, we are seeing 40% of women physicians go part-time or leave medicine altogether.
Wow.
Right.
And do you think that's because of insurance and reimbursement, or what do you think that is?
I think it's burnout. It's a lot of things, right? Because the other thing, and this is not a knock to my male colleagues, I have some amazing male colleagues who do a phenomenal job with patients, but there was a study that was done, I want to say a few years ago now, where they looked at the number of in-basket or portal messages we get from patients. Female physicians got 26% more.
Wow.
Because we were more apt to answer. Right. And then it becomes and that's not just from patients, it's from staff as well. They will come ask us questions. And then with the administrative burden, instead of being able to be in a room with a patient, it burns people out. They don't want to do it anymore. Right. And I can understand that. It's hard to be charting in your pajamas when you're at home or messages. So I think it's a multi-layered, multifaceted issue. I think those of us who are doing it, we are trying to redefine what that looks like. We are really pushing to advocate for patients, making sure that we have time. And it is hard. I mean, my state is currently going through an endocrinologist shortage. I think we did like a community survey, and they said in our immediate service area, we were down 6 endocrinologists for the community. And for the greater, larger service area that is several miles in either direction, we were down 12.
Wow.
Yeah. So if there's an
there are just more endocrine disorders that are like, it's not getting any better. I mean, that is very scary. Like, and here's the thing, like, especially because we have many men that listen to us as well. We're not saying men are bad. We're not saying no situation. We're just identifying that there is a problem and that there is an issue with the system, and that these things, this pressure and this issue is likely contributing to that, and identifying that and figuring out a way to advocate and move through it doesn't mean that any of our male listeners are bad or that anything like that. Like these are just facts and things.
Visibility.
And men struggle with metabolic disorders, right? And men who have struggled with overweight and obesity face the same amount of discrimination and stigma that female patients do, right? But the experiences are slightly colored differently depending, gender does have something to do with it. But my goal is to try and help as many people as possible. I think, unfortunately, with the way that things are going in medicine and the tenability of the system, that's where we start to see a lot of pressure on whether we can actually have enough specialists in an area.
Yeah, absolutely. What do you, we don't have to get into this now.
No.
I can take it out. what are you thinking about AI in the medical system? Like when it comes to this, like, especially, do we think it's going to help? Is it going to hurt? Like, are we going to get more specialists, less? Like, do you think it's going to affect things in that way?
So I don't know about like its medical capabilities yet, but I will say one of the ways that I've been using it over the last year has been in a co-pilot form where I have it on an app on my phone. I turn it on with the patient's permission because Washington's a two-party consent state, so you got to ask everybody. And it listens to my visit. It writes the note for me, including the plan that I verbalize to the patient. So the amount of time that I'm having to sit there and do administrative work has gone down. And I feel like I'm a better doctor over the last year because I can actually, instead of sitting there trying to type while I'm talking to my patient, I can actually sit and look you in the eye, have a whole conversation with you, do the thought work in the room, come up with your plan, and then go from there, right? I did have a patient of mine who works in tech, and it was really funny. He was like, I put all my stuff in ChatGPT and I want to pressure test it with you. And I was like, oh, what does that mean? And so he was like going through the list of stuff that he thinks, like his symptoms that he thinks may be due to the condition that I see him for. And, I'm not worried about ChatGPT taking my job anytime. It was all wrong, right? It was all gobbledygook. None of it made sense. There is a newer AI platform called Open Evidence that I actually really like. It's a partnership between an AI company, the New England Journal of Medicine, Journal of the American Medical Association, and you have to be a clinician to use it. They ask for your NPI number, but when you put a question in there, it will pull all the most recent studies associated with your question and give you all the evidence for what you're looking for. Right. That
is fantastic.
That's fantastic because it saves me time. Right. So anything that saves me time and allows me to engage more in like the mental practice of medicine and diagnosing and treating people and trying to put the pieces of their puzzle together, I'm all for.
Well, and I think also repairing trust, right? Like, because that's one thing I'll tell you. I mean, here's the thing. I've been here advocating for 3 years. I've been doing this podcast for over 2 years. I interview doctors every week that are specialists in this area, that do this, that have been treating with these medicines for years, teaching me what to do. I will tell you that even me, the first thing I do is I go to my community with questions before I go to my doctor. Yeah. Even me, Kat does it too. You message your girlfriends and you talk to your community. Like I will put a TikTok out before I will go to my doctor. And it's not because my doctor's done anything wrong. It's because I don't trust the system. And I think that's so deep. It's so deep. That is that point that Sabina was talking about this being the pressure to actually change the system, because she was saying, like, and also the amount of people that have obesity, the amount of people that can't get access, so we're all just like sick and dying. And we can't get access to the medicine. Like we've got to change things. And I think she's so right. I saw when she said that to me, I was like, I think what I do might be like even more important, because I think that's true. I think what we all do is actually more important from a bigger level than just changing things for obesity care, but it's for changing care in general and how we do this, because this isn't working. Can we all just look around and go, this isn't working?
Nobody thinks it's working. It doesn't matter if you're Democrat or Republican.
It doesn't.
It's not working.
No,
it's not working.
It's not working. Everybody is suffering at this point.
Yes, needlessly. Many people needlessly. That's what's so hard.
Yeah. You know what's funny, Kim, is that you talked about going to a community first. I talked to a patient yesterday who had side effects, and I was like, oh, you should talk to your doctor about that. And they were like, I'm too scared to tell my doctor about my side effects because I'm worried that they'll tell me that I'm not a good candidate for the medication.
You want to know a hack to get insurance to cover your GLP-1 prescriptions? Here's the truth. Most people get denied the first time that they try, and insurance companies are betting that you're just going to give up. But you do have rights, and you can appeal not just once, but multiple times. The problem is the process is confusing and it's time consuming. And a lot of providers just don't have the bandwidth to be able to fight through it with you. So that's why I partnered with Claimable. It's an easy to use tool that helps you build expert-backed appeals proven to work. So don't give up on your shot at coverage. Exhaust your appeals. Go to getclaimable.com/plussides to learn more and use code PLUSSIDES with a Z to save.
Want the fastest working GLP-1? For half the price, Roe now offers FDA-approved weight loss injections cheaper, with results you can see faster. Lose 15% of your weight with the formula from Eli Lilly that hits not one, but 2 hormones to curb hunger and nausea. Weight loss, faster. Confidence, higher. Price, cheaper. See if you qualify at ro.co/TV.
Yeah.
And I will be taken off of it.
That has
and
been
I'll lose access to this thing that I feel like is giving me control of my life.
Yes. Yeah. They think, like, I'm writing a book. I know, shocking. And it's called Our Last Shot. There you go. Welcome. Not time for pre-order yet. It's not written, but that's what it's called. And it is literally about what we are talking about right now, which is the fact that the reason people will not go to their doctors is because they feel like this is their last shot. They really do. They feel like this is their last chance, their last opportunity to get it covered. They can't get a surgery. Maybe they failed surgery. They don't want to tell their doctor because they're afraid they'll take them off the medicine. They're afraid that they'll say like they won't prescribe anymore. They're going to have to find a new doctor, going to find a new prescription, go through PAs again. So they come to us. And I don't see that getting any smaller. It's just getting bigger. And so why? Right?
And
that's the question.
Yeah. And I think it's complicated, right? And I'll share an experience with myself as a patient, right? I started on a medicine for my psoriatic arthritis. And I live in Washington State, where we have like a lot of wineries and wine tasting rooms. And, you know, I enjoy a nice glass of red. And I went out with my friends for dinner one night, and I only had like a glass and a half of wine. And the next morning I woke up like completely hungover. And I was like, what is going on? Right? Like, am I that much of a cheap date? I can't be that much of a cheap date. I know I haven't had a glass of wine in months, but good Lord. So I didn't think anything of it. But then like 2 weeks later, I went out again. And this time I was like, I'm just having a glass. So I know, same thing. I woke up hungover the next morning. And so I was like, well, holy crap. Like, the only thing I've changed is I've started this arthritis medicine. So I'm like looking in PubMed. I'm looking at the pharmacy, like PDM, whatever. I'm looking at, every like source that is validated that I'm supposed to look at for this. And I'm coming up with nothing. And I was like, okay, I feel like I'm losing my marbles. So what do? I do what any good patient does. I go to Reddit. And there are hundreds of people who are like, yes, I cannot drink alcohol anymore, right? And I was like, well, holy crap, right? I had no idea. Fast forward to last year, I'm looking at the New England Journal of Medicine, and they're studying my arthritis medication as a treatment for alcohol use disorder.
Oh my gosh.
Right.
And still, though, the last thing you did was talk to your doctor. And you're a doctor.
And I'm a doctor, right?
Why?
Well, no, I did ask her eventually. Yeah, I don't know why. Because one, I think it was partially, I was like, I should be able to figure this out myself. I'm a doctor, right?
Right.
And I know where to look. So I'll just look, and I won't bother her because that's part of it. But I think part of that fear was also there because my arthritis medicine that I'm on, it doesn't suppress my immune system. And I was diagnosed early in COVID before the vaccines were here. And a lot of these meds do. And it was our hospital in Washington was the first one with the COVID deaths in the country. So that little hospital in Washington, y'all were watching on the news, that was us. When I got this diagnosis, I remember sitting in my rheumatologist's office and I just bawled my eyes out because I was like, I don't want to be on this med without a vaccine and then I might die. Like it just, you go through all of those things. And she gave me the option of this other medicine. She's like, it hasn't been used a lot in this, but when it works, it really works well, but it doesn't suppress your immune system. And we had to go through the same thing. It was like the prior auth to get this med for me was, I mean, without it, it would be like $3,000 a month. There's no way that I could ever afford that. In Canada, I could get it for 290 days supply.
Hey, my dad
that was the backup option because we're not that far from the Canadian border. Like I would just go to Vancouver and get my meds every 90 days. We were able to get it covered, but it was like, so I feel like that experience as a patient has made me a much more empathetic physician, right? Absolutely. And I'm willing to, and my partners are the same way because they see it with the particular population that we work with. Like people are so disenfranchised with the practice of medicine. And when you are dealing with weight stigma and discrimination, you are less likely to come in and ask for help, period, right? Even to get started on the GLP-1 or acknowledge that there's anything that's there. It's, and then as you're navigating that, I know because I've had similar things like in my head, like, oh my gosh, if I have a side effect to this medication, are they going to take it away from me because it helps, but it doesn't suppress my immune system, right? Not the exact same experience, but parallel experiences. And I think a lot of that holds us back from being forthcoming about what it is. And I've told my rheumatologist this story, so if she sees this podcast, she won't be surprised. I was on Reddit, like all her other patients.
Reddit. You want to try? I wonder.
I bet you if you ask her, she does the same thing.
Yeah,
I really do. Like,
absolutely.
Yeah.
I've had several docs on the show that have obesity and we talk like girlfriends and stuff, and
you go down that rabbit hole. It's really hard to ask, right? And it's hard to acknowledge that. And I think that it's like an interesting layer being a physician who also has had health struggles. Like the shame with asking for help was something I had to work through in order to be a better doctor for my patients. Right. And once I got over that, now like people won't get me to shut up about it. Like I tell everybody about all the things like you need to, therapy is a good thing, GLP-1s are a good thing. Like you need to go, be preventative about your heart care. You need, like we have all these tools. Science exists for a reason, right? We're not trying to have the same mortality rates from hundreds of years ago. We want to live longer, healthier lives. So let's do it. Right. But it's such a hard thing with all of the societal pressure to get people to engage.
Yeah. I think you're and political pressure. Like, I feel like that's all. Go ahead, Kat, I'm gonna come back to you. Yeah. I think that like with everything in politics, and there's always something new on the news, and nobody legitimately, like, I don't feel like anybody knows what to believe anymore, to be honest. Like even the most educated, like, well, maybe, I don't know, because I don't think we're meant to process all this information. But I think like that kind of gets us in a level of like burnout and overstimulation where we don't really necessarily want to take that next step to do that thing like in person or advocate or push or whatever. And I think that's a common thing that I see in our community for sure. I mean, which is everybody, right? Because it's men and women, Yeah.
And I would say with the physician shortage, like I live in Austin. That's a city that's grown a lot. I've had 3 PCPs in the last 4 years.
I believe it.
And my last PCP, I had to schedule an annual physical a year in advance. Mm-hmm. And then before that date came, he decided to leave the state. So, it's like, it's inaccessible. And if you don't have a PCP, which a lot of Americans don't, and you don't know what specialist to go to, that's when it's like, well, maybe a telehealth option for GLP-1 is the fastest way for me to get treatment. Because when I was starting to work on GLP Winner, I interviewed 150 patients, and I was like, when did you like mentally decide you were open to taking medication? And when did you actually get it? And often it was 6 to 12 months. Yeah. So for us, it was like, if we can speed up that timeline to treatment, we can change people's health outcomes.
Yeah. Absolutely. I think I have felt very good about the work that we do here, because what has happened is we have had specialists and we have created a library of content over 5 seasons that anybody can search at any time and binge and be able to make that decision faster. And I have felt and I've had thousands of people be able to tell me that that's been available. And it's one of the reasons we started the show, because we could see the gap. None of us really know how to solve the problem.
No.
At least people are showing up and trying, and having the hard conversations that aren't always easy to have, to be able to figure out, okay, clearly this isn't working. Like, what do we need to do next? I wonder too, like, I can't help but wonder if doctors had access to like this AI tool that you were mentioning, right? Mm-hmm. Especially if they were PCPs. The amount of time they could do for prep, right? Like, or to be able to do before any of this. Cause it's one thing to go and listen to an endocrinologist at a conference, right? It's another thing to have an AI tool where you can know about the latest studies and be able to like query and be able to have more meaningful conversations, which I think could possibly help that trust piece, because I do think that was a big difference for me.
Yeah.
When I went to my PCP, I was talking to like the nurse when I came in, and I was like, I've only lost 10 pounds. I can't figure out what I'm doing. That's all I've lost. Yeah. And this nurse practitioner sat down with me, and she put her computer down, and we sat down across from each other. And she was like, I heard you say that you only lost 10 pounds. And I think that's such a big deal. Like, it's such a win. And that's an incredible accomplishment. And nobody had ever said that to me before. And I all of a sudden got in a place to receive, right? Like, okay, what we're going to do. And she's like, let's do a plan. Let's talk about these medicines. Like, there's options, but we got to do something now, because next year we're going to be talking about some bad stuff. Right. And that's just how this works. And nobody had ever done that for me before. And I feel like one of the ways to solve this, because obviously we don't have enough specialists, and I would love to be able to solve for that thing. But if we have a lot of PCPs and they have access to tools and education, and they can serve us, because they are the first lines of defense. You know what I mean? And while I appreciate many of these telehealths, do I think that they're necessarily the one to stay with once you're in maintenance and all of that? I don't know. I don't think we do know. I think that what I've learned about being on these medicines and this disease is really complicated. And so at what point then do we leverage telehealths for either like starting and then maybe maintaining, or starting and then maybe you get to a certain way, like do we switch to specialists? Like I think there would be really great if we had some like recommendations around there. But there's also the piece too, like with telehealth access. That's why I'm talking about it a lot, because it's so important. It's so important. The issue with where people live. So we've had people on our show before that are in rural areas. They don't have access to close access to be able to see, an endo or an obesity specialist regularly, or be able to necessarily afford it. Like Medicare, I don't think even covers, right? Obesity specialists. I don't think that's what we're trying to throw up.
Depends on the plan in our state. But one of the things that I'm seeing right now that's driving me up a wall is that the insurance companies are putting restrictions that are not in line with the guidelines. So I said I'm a little spoiled in Washington. I've had an easier time getting most of my patients their meds. But the other day I was looking to approve it for somebody who had a BMI over 35 with 2 comorbidities. They had like high cholesterol and prediabetes, right? So by all intents and purposes should qualify for that. Actually, a BMI of 27 or higher with 2 of those comorbidities, people should be able to get the med. The insurance company said, no, the BMI has to be 35 and you have to have 2 comorbidities. And I was like, wait, so my patients who want to be proactive, who don't want diabetes, who don't want high cholesterol, high blood pressure, don't want to have a heart attack and stroke, they're just going to have to wait until they hit a BMI of 35 for you to give them a life-saving medication? I was so pissed.
I know. It's crazy.
So angry.
Right?
Yeah.
I've not worked in healthcare very long, and I'm not a clinician. I don't do direct healthcare. I just read
on the internet.
But I've somehow found myself in rooms with people where like that's actuary math, right? Well, if your BMI is high enough, then it's accretive to the bottom line for you to be on these medications. If it's not high enough, it's just waste and expense. I've been in those rooms where they've been talking about, well, when you get to these BMIs, it actually makes sense for them to have the medication. And I don't know how I got in those rooms or what happened for that, but I'm always shocked at what people will say behind closed doors.
It's ridiculous. And then the other thing I'm actually seeing, and this is another way I think insurance companies are trying to control for access to these meds, is now certain insurances will not allow somebody who's not obesity medicine board certified to prescribe these. So it's effectively cutting off the access from the primary care docs. So it's like we're just like squeezing people for, and it breaks my heart, because I have seen how, and y'all have seen how and experienced how life-changing these medications can be. I wish
it's really, really difficult to do this work, like as advocates, or I'm sure as, clinicians as well, and see people suffer needlessly. Like it keeps me up. It keeps me up.
Yes. And what's the other thing that's interesting is insurance will sometimes require that you go to specific provider networks or companies, telehealth companies, to get it. And I've talked to those telehealth companies. Often they tell the insurance, we're just not going to prescribe GLP-1s for as long as possible. Or we're going to get them off the medication. It's variations of that where they've sold the insurance on exclusivity if they try to eliminate GLP-1 prescriptions. And so it feels like it's wasting the patient's time. It's not actually giving them what they need, because, I mean, feel free to speak up, but GLP-1s are the frontline treatment. Like the first treatment you try, right? And so creating these situations where they put people on inferior treatments that have way worse side effects. I've had traumatic experiences with other obesity medicine drugs. Like topiramate made me forget words, and I'd been learning Spanish and made me forget all the Spanish I'd learned. It did not come back, right? So to me, I know that's a good medication for some people, but it should never be the first medication you put someone on.
Not when we know what we know now. Like, it's like, and I think like In terms of like, I'm sorry, my allergies are bananas. See me wiping my nose. I can't help it. It's running like crazy. I've been outside a lot. I have this thing right now where it's mental health stuff, the perimenopause. I live in boxes, right? Because I'm like remote and I make on the TikTok and then I do the podcast. So I make myself go outside so I'm not in a box. Like, like I don't know. It's a thing. But my allergies are bananas. So I'm like wiping my nose and recording. Sorry. It is what it is. But I think like when we're talking about like the sort of, I want to like sort of like these inferior meds, some people, and kind of I talked about it too, like do find the combination of them very helpful, especially if we're like in that kind of severity of obesity. But a lot of people don't even think to ask their doctor about them. They actually are just like, it's GLP-1's not working anymore. I'm getting my weight back. Here it comes. And then they think they need to do more meds. And they're figuring out their own. But this combination therapies are things I think you could probably speak to. Like, have those been successful? I have found them very helpful.
The combination therapies you mean by like the GLP-1 plus the GIPs or
like,
the
Wellbutrin
plus Wellbutrin? Yeah, I mean, I think that there's more and more data that shows that should be it. We also have our patients, like I have a few patients post-bariatric surgery who start to have regain, who had metabolic disease prior and the diabetes is coming back, and they do great on GLP-1s, right? And so I think that we have to evolve our thought pattern, just one thing should be enough. When in the history of medicine has that ever worked? That's why people are on like 3 blood pressure medications, right? It doesn't work that way. And I feel like we are limiting our thought bubble around that. But there is data coming out that shows combining therapy or treating post-bariatric surgery even to help maintain weight is the good use of these medications. The problem, I think, is the cost, right? And I am all for people protecting their intellectual property, but when a drug patent lasts 20 years and then you go through the process of quote unquote evergreening, where you get a patent for a second indication, you're basically making generations of people have to wait for it to come off patent in order to get it. And then even despite that, right? Even if it's on patent and we have to buy the brand name one, why does it cost $1,000 here and like $150 to $200 in another country?
Yeah, absolutely.
That's criminal in my opinion. And I think that is, unfortunately, I'm probably going to get filleted for these comments somewhere, but I'm not a speaker for anybody, so I can say, nor will I ever be at this point. So I'm just going to say what it is I want to say. It's really hard for me to justify that. If it costs you $5, $10, $20 to make the medication, I can understand charging $200 for it, but $1,000,
$200, that's
well, and and you think about the cost of 200 being accessible to more people versus 1,000 makes it exclusive. Would you just have more people then be able to get it and be able, and again, I'm not a business person. I don't know about supply chain and manufacturing, all those things. I'm sure that's complicated on its own. But to me, it's like we're doing the general public a disservice. By allowing that to continue.
Well, and it's not even like if we think about it sort of limited almost in a way, like people have to wait to get on it. It's not just that. It's that people are slowly dying and suffering, and then they do die and they may never get on it. And that is a travesty. And I think like I recently, Kat and I went to this event that was like called In Real Life, and we met with some major executives like Coke, Pepsi, like all these different people, Tyson. And one person was representing payers, and she was actually lovely and so open-minded and fantastic. And she was like, "What are we supposed to do? Like, it costs so much. Like, how can we even do it?" And I was like, "Look, like." We had Dr. Kessler, the former head of the FDA, come on and go, at this point, we do have a cash price of $500. Like, we do have that. You can get brand for $500. A company can split that with you. Like, split it with the patient. Like, they can cover as instead of paying for stupid ass like Weight Watchers or whatever. Sorry, I've got issues there, but waiting for like some sort of plan to do this or that. Like, split the cost and have the patient be actually able to treat it, because ultimately all their stuff is going to go down. The plans are going to be less expensive. Everybody's going to win. Like, for the most part, statistically, everybody's going to win, but we all got to give a little, you know what I mean? It's like when you're in traffic and you got to let someone in even if you don't want to, because we all go in the same place. We got to let people in, because if you're just sitting there and being a jerk with your foot on the brake, you
We're
got to
not
figure out a
going
way
anywhere.
to
You're still not going to get anywhere. You're not going to get there any faster.
Yeah, you're not. I promise you. Like, you're not. Yeah. And it's the same kind of thing. And I think if we all realize sort of this idea, right, that this is this underlying dysfunction that is literally killing at least like 40% of us, right, slowly, with all of these additional diseases, and Medicare is paying for obesity. They're just doing it on the back end, right? They're paying for the heart disease and the dialysis and the, you know, for diabetes, all this. Let's cover it on the front end and try to get ahead of this. But everybody's going to have to make a sacrifice to get this done. But it does affect everybody. And that's what I know I rant about that a lot, but it is, and anybody that knows me, especially in this room, they know I'm not political, but this is political, but this is just not partisan. Like, this is a problem that everybody, I think, understands.
Equity, right? And it affects everybody, to your point, regardless of party.
Yeah, like the $500 a month direct to manufacturer requires that you don't have insurance reimbursements or employer or payer reimbursements.
That's where I think that we need some sort of something in place.
That's the rub.
And I was trying my like split dosing, you know, like prescribing a higher amount. They're like, if you don't refill it within 45 days, the price goes up to like $100 $1,000. And I was like, well, there goes that option.
We had someone on from IMAC, which is a company that really is kind of talking about the loopholes, like in the patent system, that are exploited, and kind of all the ways that you were just talking about. And he was like, they were playing 4D chess. They will hold off on the price drop and all the things. They are way ahead of us. You know, and I think that's true. They know how this is done. They know how this system works, and they know, and I don't have any problem with people, honestly, like making a profit and winning and all of those different things and bootstraps. I really don't. I really think it's great. I think that's wonderful about America. I do. Yeah. But that's not what's happening, right? Like, it's egregious. And we do have to, I think, as a society, say when something is egregious, and this is just out of control, and we got
I agree.
You know?
Yeah.
I don't know how, though. I guess we just keep showing up. What do you think?
I think that's all we can do, right? And keep trying to push the needle and make sure we are advocating for people.
Absolutely. Education and advocacy. I think, you know, just try to show people grace. So I think if we get to a place where we can forgive our doctors and our, you know, our PCPs can learn more about this, I think that is one of the reasons, like we're talking about, you know, because, you know, there are some flex or some HSA or HSA that will actually say, like, you can use this one and they have compound and you can pay for it. And so, like, I feel like we're kind of heading in that direction, right? And if that's the option, then that's the option. But if there's some sort of assistance, right? Because even $300 a month, like, it's a lot. It really is. And it does continue to not serve many, many people that need this, you know. And I just think we just got to keep talking about it. Just keep talking, guys. We'll get there.
Yeah.
Try to show up in person, because I have found when you show up in person, things move forward. It is very easy to ignore you when you are just digital. It's a lot harder to ignore you when you're standing in front of somebody and you're a real human that bleeds. Like, it really is. And I found that to be very powerful.
I think that's true for any facet of life, right? Like, you think about just like all the haters and the trolls on TikTok. Like, I started getting a little bit more traction on my posts, and then there were some wild comments in there. And I think, you know, that anonymity behind, like, being behind a screen, you would never say stuff like that to somebody.
Absolutely not.
Right? And that's why we're so divided. We spent 5 years isolated from each other during a pandemic, and, you know, people lost their social skills. You know, and we're polarized in all areas of life right now. It's it's kind of scary and hard to watch.
It really is. And I think more people are starting to wake up to recognizing the piece that social media plays in this.
Oh yeah.
You know, at least I hope so. Because like, if someone's constantly in this, we bias is a thing we talk about on the show.
Yeah.
But if you watch something, everybody has bias. You don't have a bad person because you have bias, right? Like, but when you have bias and you are engaging with whatever, right? Because that's what your brain likes and whatever it is, right? Then what's going to happen is you're going to keep seeing that over and over again, and it's just going to reaffirm your bias. And I think that bias eventually turns into like a doctrine and then a religion. And then before you know it, everybody's your enemy if they don't agree with you. And I think that the way that social works and the way that you are almost incentivized for getting more views by misbehaving and making people angry, I think that is really contributing to a lot of this. And so what I'm trying to do is just take a step back and realize that I'm letting them manipulate me, and make sure that I follow different viewpoints in person and on an algorithm, because I don't want to be frankly made a fool of. And I think made a fool of is if I'm just like following things blindly. And I just don't think that we're in a safe place where we can do that.
No,
you know, so I think like as we're trying to change the system, guys, the algorithm, AI, that's part of the system now, right? And if anything is just going to make it more so. So just think about that as you go through things. And even when you listen to our show, consider different perspectives. There are plenty of people out there that disagree with us, you know, not many, but there are. You can listen to them too. Just Well, this has been a lovely conversation, friends. Thank you so much for coming, and Sabina for sharing your story and helping us learn. And hopefully this has been a good one about our system and, you know, how we can change things, I think. And everybody just do your little part. That's all you can do. Okay. Yeah. And we love you, and we will see you next week. Hasta la pasta.
Thank you.
Denied coverage of your GLP-1? Do not quit. That is exactly what insurance wants you to do. You have rights, and you can appeal more than once. Claimable makes it simple with expert-backed appeals that actually have been proven to work. Check out the link getclaimable.com/plussides and use code PLUSSIDES with a Z to save.
Want the fastest working GLP-1? For half the price, Ro now offers FDA-approved weight loss injections cheaper, with results you can see faster. Lose 15% of your weight with the formula from Eli Lilly that hits not one, but 2 hormones to curb hunger and nausea. Weight loss faster, confidence higher, price cheaper. See if you qualify at ro.co/TV.
Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on the Plus Sides, Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus Sides, Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together, because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault.